Assalamu alaikum, I'm Dr. Thaira and you're watching program Health is Wealth. Ramadan is approaching and the spirit of giving is in all of us. It is said that saving one life is like saving entire mankind, and what better way other than donating blood. So this Ramadan, let's pledge to donate blood, because one pint of your blood is going to be saving 3 lives. Assalamu alaikum, welcome to another episode of Health is Wealth, and we're approaching Ramadan, and Ramadan is all about giving, the spirit of giving. And giving is not only, charity doesn't confine yourself only to monetary benefit of food, but it's the gift of life as well. We're talking about blood donation today, how important it is and how you can actually save somebody else's life, how beneficial it is for your own body as well. And we'll be talking in detail about all blood dyscrasias, blood disorders, everything that you need to know about our national blood policy. And we're so grateful that today, we have been given the time by a very renowned hematologist who's been doing phenomenal work in this regard up till now, for thalassemia, for all sorts of anemias, for blood transfusion, blood and everything related to blood. Thank you so much, Dr. Nuzhat Mushahid, for joining us today. She's a hematologist, she's a specialist with blood. Thank you so much for your time. Let us start with the most important aspect of blood donation. What are the benefits of blood donation for the person who's donating? Who can donate blood? What are the policies surrounding it? Because you've been involved in writing the national blood policy as well, and you're in, and since Ramadan is coming, people are more and more about giving. So I think it's the best time to tell them about it.
Thank you. It's such a pleasure to be here again next time, talking of the same things which are very close to my heart and very important as well. As you have set the stage, certainly it is about giving. It involves giving. It is altruistic for sort of thing that anyone can aspire, which doesn't take much except for your little time and little effort. But it makes a huge difference for lives of people who, and not only one donor can actually save 3 lives. And why it's so is because we divide the blood product that we get from the donor into 3. That is the red cells, the platelets and the plasma. The red cells are required to carry the oxygen. So anybody with anemia or where their oxygen carrying capacity is poor, so they need the red cells. Platelets are for clotting the blood. So we separate it, and those who have problems with clotting blood, we give them platelets. And then we have a plasma, and plasma again is required for clotting. And not only that, it is a basis for forming many precious drugs. And as you talked about policy, that was mainly for the aim that the plasma which is being collected in the country should not be wasted, because it always remains the surplus or it is not formed. So certainly it starts off with whom? It starts with the blood donor. And blood donors are the most important people in this chain. Regarding this Ramadan, as you rightly pointed out, it's not only about the giving, it's also knowing and appreciating that why Ramadan becomes a very special time when we need to actually reach out to our donors. Because by virtue of our fasting and then breaking the fast cycle, the donors are not available to us. And it is not that the patients are going to wait for Ramadan. Exactly. So they are coming all around the year, and during Ramadan we have acute shortages. Right. That's why we tend to, those who blood bank services, they tend to actually reverse their working as well. So they tend to have more people working after Maghrib prayers, so that they can get the more donors who after breaking fast can actually donate the blood. Right. So the requirement is that the donor would have no more than 2-3 hours fast before they come to donation, because we don't want them to be fainting. But we are very well prepared. Any good centers, and the definition of the good center or a blood bank is that where the regulator has actually given them a license, saying that we have seen their processes and procedures and they are doing a good job. So any licensed blood bank, I would urge the donors to particularly donate in groups before the Ramadan starts. That's the time where you can actually take that inventory for at least 20-30 days. Right. Then secondly, of course, they must keep in mind that during Ramadan they would have shortages, and anybody who is volunteering should come after
Okay, so
Maghrib.
who is eligible to donate? For example, what is the ideal age, the ideal weight? What if they have diabetes or hypertension or they're on certain kind of drugs? How often can they donate, and what are the benefits of donating blood? Because we know that, once you donate blood, you yourself also get a lot of benefits. When you get first you get a free blood test, and secondly, you also your whole blood is regenerated, and you stop having a lot of heart and clotting disorders and all of that. So how beneficial is it? And who are the ones eligible for it? Who are not eligible as well?
Okay, starting with who are eligible. We have a criteria. Of course, that is set with our national standards and many international standards that are being followed as good practices. We start off with the age limit, that is 18 years, and it's not that because they are physiologically unfit, it is because that's the age of consent. Yeah. Before that age, the parents would need to give the consent. Secondly, the donor should be feeling well on that day. And then they should not have history of hepatitis, treatment of hepatitis, or having a high risk behavior which makes them prone to HIV and other sexually transmitted diseases.
But unfortunately, a lot of addicts keep selling their blood, and a lot of people do this, and then when they go for blood, they get contracted blood. So what will you say about this, and especially the spread of hepatitis because of transfused blood in our part of the world?
That is certainly an unfortunate part. They still do come inside the blood chain, but this bad blood or those people who are selling their blood can only be replaced with volunteers who are healthy, known to be healthy, who don't need to sell their blood to take care of their drug addiction. But I tell you one important thing that I have recently noticed since I am in this field. And after coming out of the background of military, I went and I was exposed to a lot of public and private sector. One very concerning thing is that our universities and colleges, there that we have a lot of addiction, and there are now people who are engaging these people. So all those people who are asking for blood, the first thing is that still I think the replacement system or them family and friend is better than there's these, and the best would be to have volunteers who round the year. Now here I want to make another very important point. People think most of the time in our country especially that whenever anybody is going to ask them for blood donation, whenever anybody is going to need, then they're going to go and donate. No, that doesn't happen. The patient can't wait, especially for the emergencies. They tend to require blood within half to 1 hour, especially I would say the obstetrical hemorrhage, where the maternal mortality is attributable half of that because of the lack of blood or accidents or some unforeseen bleeding. So this concept by virtue of this program, I need to very important message is that you need to get associated with a blood center or a blood bank, a reputable one, and you need to go there after certain frequency, and that frequency, as you asked, was 3 to 4 months.
Okay. So for every 3 to 4 months, it's safe to go.
It's safe to donate. So you should automatically go there, get yourself associated with that, so that the blood bank has enough inventory that whenever there is emergency, they give the blood. They're able to provide the blood, and not only that blood, all of the component. So this concept needs to be corrected. Why this concept has come into our culture and society is because the blood donor organization have started working on their own, and they have not been led properly by the professionals who need to explain to them the concept that you need to be associated with the blood bank. The blood bank need to tell them that your inventory is getting low, so we will not be able to serve the emergencies, so you need to come and donate to us. So it should be like, now people have even promoted group of 20 and 25. What that means is that you vow to yourself saying that I'm going to donate at least 20 to 25 times in my whole life. And you make a commitment to yourself. And I tell you, you were telling about asking about the benefits. It's the feeling, it's the the goodwill, the altruistic feeling that you get. There's no match to it. You feel good about giving a part of yourself, which doesn't harm you. In fact, it benefits you in a lot of way. You as saying you generating new blood, and this blood volume gets compensated in less than 24 hours, and your red cell gets compensated in 2 to 3 months. So every 3 months you are able to donate, and there are on record you have mega donors even within our country. Lately, one of our mega donors Jansab, he died, he was an eye specialist. He donated 140 times in his years.
Oh my God.
And the last time he's donated, fortunately, at my center was when he was like 80. So, yes, there are certain other contraindications, like we would always investigate. A good blood bank and blood center is going to investigate that, you know, what sort of risk behavior they have, what exposures they have, they are not having, and of course they need to examine them, look at their blood pressure, their pulse, and also look,
what is the
especially
ideal
with
weight?
the signs, look at signs of not having a drug injection. Right. Yes, the ideal weight we take is any weight above 50 kg, okay. But that does not mean we cannot take less than 40 kg, but then we do the little adjustments and then anticoagulant.
Okay, and in one sitting, how much blood can you donate, and what are the precautions before donating blood, the care to take after donating blood, and which are the ideal places that they should be going? For example, today after watching our program, a lot of people think, okay, I'm ready to go donate blood. So where should they donate? Because blood, after blood donation, blood storage is a very important factor. Transport of that blood so that it doesn't get wasted, and then the fact that this blood is actually provided to the right people at the right time. So how do they need to choose? Because I just know about Red Crescent for now. I would like to know more and more centers that are offering this service so that people in cases of emergency, surgery, accident, instead of, you know, messaging to all their friends and everything, getting into panic, we need blood, they know where to go.
Starting with this, the safe blood volume that need to be drawn is around 450 milliliters, and this has to be automatically calculated, and there are equipment and instruments which tell you that now this much volume has been collected, and throughout collection they tend to shake the blood. So any good blood center, any licensed blood bank and blood center should have that. Then the precaution would be that these donors should come with having some meals and fluids so that their blood volume is good enough. If they don't come with, at least at our blood bank we offer them the juices and the fluids and even the meals, light refreshment, so that they are able to, you know, tolerate the volume changes. What precaution afterwards is that they should not be working at heights. They should preferably not drive in 12 to 24 hours. That's all. Not many.
Nothing else.
Yeah, nothing else. But of course, a good center would be very prepared that if there's any untoward reaction, the donor, that would be managed well. As far as you were aware of Red Crescent, of course there are public sector hospital, and among the private sector hospital there are many, and especially look at that where they are offering the emergency blood services and they are licensed well. For example, the PFS blood bank .com, if they go on their website, they would find out that's a category A plus license by the Punjab Blood Transfusion Authority, and it's the only category A plus private blood bank. It serves many hospitals, so that it has a huge, it's a good capacity, and it has multiple places where they can donate. And of course, if they have experience previously and heard from their family and friend where they had a experience with a good blood center, that's where they need to associate, and that also helps them actually going nearby. Right. They don't need to go, you know, very, very far off. So it's the spirit that matters. It's the being empowering the blood bank to actually building their capacity and inventory so that they can help the people whenever the emergencies arise. And this particular time, you know, Ramadan is really, they need to, I would urge the donors to get to bring their family, their friends who they think would be eligible enough to come and donate at these places. And one of them, I told them that right in the heart of the city in the Sadr, that is one of them, and there are many others. So they should make it a habit.
And what about diabetics and hypertensives? Are they allowed to donate blood? Pregnant women? No, definitely not.
Yes, pregnancy is definitely a deferral condition, but for blood pressure we have limits, like the upper blood pressure we take is 140 and the lower blood pressure 90. And then diabetes, if they are on oral diabetics, we are not, that's not a contraindication, but they are insulin. But the more other important thing is we look at if they have a cardiovascular disease, we would not want. If they had a previously, you know, cancer treated, if they had some other disease.
If they're on blood thinning medication and
yes,
all of that.
That is a long list. We look at the eligibility criteria and in fact give a questionnaire to the donor. That's the right way, so we tell them, and of course we take consent that they need to be told that what will happen to their blood, and they are doing it willingly, and what tests will be done. And of course, as you mentioned, 4 to 5 of the mandatory tests are done, and at least at our blood bank we have a policy that we send the reports of that is like screening for hepatitis B, C, HIV and syphilis every 3 to 4 months.
Exactly. It is very important for everybody to actually get screened this way, and in fact they say that there's absolutely no disease that can't be detected by a blood test. So if we talk about the normal CBC, complete blood picture rather, not count, complete blood picture, what does each parameter tell us? That like the number of RBC, WBC, platelet. I know it's a very basic question, but I would like our audience to know how important it is, because people think, oh, we went to the doctor, they gave us CBC, it's not important. Why did he just treat us? So could you just highlight why it is extremely important for screening as well, and even otherwise, your blood is telling you your whole story.
Well, that's very interesting. Historically speaking, there's a lot of myths around blood. Maybe we can have a full session. It's a absolutely very interesting history where even, the Romans, their warriors, they used to think that their blood is actually the source of their power, and all those audience, they would come, and once those fighters would go down, they would have their blood, putting on their, and there's a lot of things. But yes, certainly it's a source of transportation for all the nutrients for all over the blood, and it's a very important thing because you can see that it serves all the organs, serves with the nutrition, serves with the oxygen, brings the dirty material from there, some of that gets out of the lung and some of them get out to the kidney. So certainly now coming to this point, as you said, that CBC, from that I actually am going to bring another concept very clear to my patients and maybe my colleague doctors as well. You see, there's no way that not the labs have come to that level that you go through that and in the end you will have a sort of a diagnosis. It doesn't happen right now, maybe in somewhere in future and whatever. The doctor need to look at the patient's problem, need to ask the patient, give time to the patient, and only then write the investigation which they think is going to be based on what they have thought. And secondly, another point that I want to highlight, again, it's a concept that the people need to clear, that it is not that we want to make all their labs normal, but certainly we want them to be in a reference range.
Right.
And that's why we use the word reference range. And for blood, it's important parameter that we start off is that when we look at a lower hemoglobin, then the second important parameter is we look at their size of the red cells, and which we call as MCV. Because we tend to classify the anemias based on the size of the red cell. That's one way of classifying the anemia. There are many other ways, but this is the simplest way. So when there you have a lower MCV, then what we differentiate is we have to differentiate between iron deficiency, which is very common, very prevalent in our country, especially in the females. And the second thing is that we want to look at their thalassemia trait status. That's also common. And that will bring us to another point as well. We will come to that.
But let's start at anemias first. Anemia is extremely common in our country, in females, as you said, the poor diet as well as bleeding, every month's bleeding, and then uncontrolled bleeding from many sites for other people as well. And people don't know that these are the symptoms of anemia. They're getting breathless, they keep going to a cardiologist, they keep having melasma, they keep coming to a dermatologist for all the fancy treatments possible, but they will not go to, won't address the issue itself. So first of all, what is iron deficiency anemia? Why is it so common in our part of the world? What is the other anemia, the vitamin B12, megaloblastic anemia? And how do you counter or how do you treat any of these anemias? Before we move to the other thalassemia, let's just go focus on the first one.
Okay, now let's start off with a very simple statement, that is anemia is a symptom of something else. Right. So if you have anemia, then we need to differentiate whether it is a nutritional anemia. One of the top is iron deficiency. Right. And iron deficiency, last time I was reading a report within our country, 3 billion, rupees are lost annually because of this thing. So, and the commonest is in the female. And the reason is, as you said, there are ongoing losses, poor diet, and mainly these two factors. And losses, sometimes they are very huge losses, and the people will not even appreciate, the ladies, that they are actually having very abnormal one. Last time I saw that the girl was having a menstruation, probably heavy menstruation, because of some bleeding disorder, and they thought it's a normal thing, and she will get into anemia again and again. So iron deficiency is the top. And here I want to also correct the concept that iron deficiency correction is the best source of iron is actually meat, red meat.
Okay, so they should be given red meat. They keep
Yes.
avoiding giving eggs and red meat to girls, saying it's not good.
Apple and spinach is a bad iron; it doesn't get absorbed. But apple and rest of the things are fine. But it's basically the heme iron which comes from the meat, which should be part of the diet. And of course, if somebody is bleeding heavily, they need to look into and get it treated and replace that. Secondly, the other vitamins that are important is the folic acid and vitamin. Folic acid, by the way, mostly comes from the vegetables, fresh vegetables. Right. So that's the main source. And B12 again is a source, is the meat. So meat is very important. And also I'm looking at another phenomena. It's not that you are nutritionally challenged class, lower socioeconomic class where you are not able to afford the meat.
The high class isn't
exactly.
taking it because of weight problems.
Because of that, and that is another phenomena that I'm seeing. They can afford it, but they're not taking because of their dietary reason. And somehow this chicken thing and white meat has somehow, I don't know, its availability or whatever. So the parents should make an effort that they need to give the red meat to the, and above all, there's no problem if you can, if you have still deficient and you're not, the iron preparations are very cheap.
Right.
You keep on taking them.
Exactly.
That's not a problem until somebody has a, they come to menopausal age. So again, B12, as I said, and folic acid, they again would have a different reason, starting from stomach to intestine to, all those things. But that needs to be first diagnosed. And of course, that's the first thing, screening test is the CBC, where somebody is going to look at it and give you a report. But important thing is that the doctor who needs to talk to the people, it's anemia as a symptom, you need to look at the cause and treat the cause.
Now we have so much of thalassemia in our country. We have no concept of prenatal screening. We have no concept of, if one child has gotten it, that we realize, okay, before the second we need to think about it. Could you please talk about thalassemia prevention? What exactly is thalassemia trait? How is it, transmitted to the next generation? And what is the life of a thalassemia patient with all those repeated transfusions and everything else?
Okay, you have really touched a very tender wire with our hearts. All of our hematologists are extremely compassionate, of course worried. It's a genetic disorder. What happens is that you have a mutation in one of your genes, and this mutation, if it happens only you carry one copy of that mutation, either from the mother or father, it is called the carrier state or a thalassemia trait, where by and large you would appear normal, except that sometimes you would have associated iron deficiency, folic acid, B12. You don't get immune with that. So it is that they would carriers would, if they tend to, the more or less they are incidentally diagnosed. And only when they are marry another thalassemia trait and a carrier, that during their pregnancy there is a probability that the two genes would be combined together in a child, and that would result in a disorder which we call as thalassemia major, where they are unable to produce the normal blood, and then they would be dependent on blood transfusion. Now here I want to clear that starting off how much of a carrier state we have in our country from different racial and ethnic groups. We have different, but on the average we have 5 to 7% prevalence of thalassemia trait. So out of 100, 5 to 7 people are thalassemia carrier. And you know what, when these, we have also a socio-cultural setting where we have a consanguineous marriages, cousin marriages, so that it tends to be the thalassemia and to happen more in certain families because of this consanguineous marriage. Still it's 60 to 70%.
Exactly.
So it's important to know the messages that people should know, that in our population 5 to 7% of our people are carriers. If they marry a carrier, there is a probability that they will have. What is the probability? Every pregnancy carries a probability of 25% to have a thalassemia major child, 25% probability that they will normal, and 50% probability they are going to be carrier like their parents. Now, since it's such a huge, I would say, tragedy in a way, that the lifelong transfusion and this transfusion leading to iron overload in the child, they used to succumb in very early, but now the lifespan is extended to little teens, but still because the optimum treatment would cost in our country 200 to 400,000 rupees a year. So many people will not be able to afford it. Not many places are there. Of course, over the time, the lot of non-governmental organization has come up. But the thing is that people need to understand it needs to be prevented. It cannot be treated in that way. Yes, we have a curative treatment of bone marrow transplant, but how many people can afford that and access that? It's costs about 18 lakh to 20 to 22 lakh.
But is it successful for those who get it done?
Yes, it is. It is. Certainly, if they have a matched sibling, the chances of getting a good transplant is quite high. But I told you how much of this is going to cost. So anywhere in the world, people have only prevented it. There are remarkable examples, Mediterranean countries, where they had a very high prevalence of the gene they have. So we also need to, because we desperately need to prevent it. So what is the volume? It's like we have 100,000 children at one time, spread all over the country. And every year we are adding 5,000 to 7,000 new thalassemia major. It's a huge burden. And you can gauge the burden from the very fact that we are collecting about 3 to 3.5 million of blood each year. About 1% of the population is donating or requiring the blood. Out of this, 0.7 to 0.8 million units goes to thalassemia major. So this blood that is going to thalassemia major is depriving the other places like oncology, cancer patients, renal failure patients, obstetrical hemorrhage patient, emergencies and surgeries, so many other. So over the time what has happened is because of the thalassemia non-governmental organization, I mean, I don't want to go into the details that why that, of course there was a gap and they needed to do something about, and they were doing, many of them are doing very good work and compassionately doing it. But the thing is, they are either not concentrating well on the prevention, they need to offer, because the science in our country has proven, the evidence is there because of a very great scholar who has dedicated all his life to thalassemia major, Jan Sohab. So his seminal paper published in New England Journal of Medicine says that we need to do the targeted screening. And targeted screening means that because it's trapped within the families, because of consanguinities, everything. So we need to have the thalassemia major who is with us, trace their family, pick up the carriers, counsel them, and tell them that before, during pregnancy, they can undergo a test. This is what you tell. That is what you're telling, the prenatal diagnosis. So we need to, we are duty bound at all levels, including government, and responsibility of all people who at different organizations and institutions who have well-developed facility to provide a prenatal diagnostic facility. But the important thing, more important, is that people need to be aware that there is a carrier state. There is a risk that if they marry the carrier, they are going to have, they're potentially going to have a thalassemia major child, and that's going to be a big difficulty in their life. So this need to be prevented. So lately, because of this thing, because of massive, of course, we had we needed to pass a legislation. There's a Sindh has passed the legislation somewhere about 4 or 5 years back, but no progress has been much made on that. Punjab has not passed the legislation. The bill was presented, but they have progress. They have made a institute where they're preventing, and there is a program running there. We appreciate that out, but it needs to be scaled up further. Good people are involved with that. But we thought that, and I think that's not only my personal perspective, it is every, I think, sensible person's perspective, that we need to have a national program, declare it as a national emergency, and do a big scale up of this preventive program. And this goes hand in hand through programs like you need to make people aware that it's a huge and difficult and important problem, and we can do something about it. So doing about is that I think it will be, sometimes take a most of the time takes a simple CBC to find out that this person is probably a carrier. And then you need to just confirm it. And I hope that the newest policy that people are striving for writing as a national blood policy for not only this, but other genetic disorders.
What about sickle cell anemia?
Yes, it is common in southern part of our, where we have the Makran coast and certain Quetta, Balochistan, some areas, but biggest problem is thalassemia and few other thalassemias. but it's mainly beta thalassemia that is the most prevalent.
So when somebody goes for a CBC and they get their hemoglobin tested, what is the ideal hemoglobin in males and females? And then it's not just the hemoglobin, the number, but the type also that we need to test?
Yes. So any good hematologist would be able to, and you know, interestingly, because of my passion for this thing and because of this disruption of AI, I am working with an AI team to actually make a app whereby I can just upload the CBC, and we can actually, anybody can on their mobile phone will say there's a high probability that you're thalassemia trait and get it confirmed. So if it's a general knowledge and it's a cheap test, CBC is available everywhere, and it's cheap sell, and if we have something which AI is assisted interpretation as well, they just need to go and confirm. And the important thing would be that before getting married to boy or a girl, they can ask and screen them. It's not that we are saying that they should not marry, but it is they should be cautioned and saying that if you're going to marry, then it becomes their responsibility to get them screened before 16 weeks of pregnancy, before 4 months, so that they come to know that if both of them are carriers, then they need to get the prenatal diagnosis, where a needle is put into and a part of fetus is brought out. It's a very safe procedure in good hands. So that we can find out whether the child is thalassemia or the fetus is thalassemia.
So there's a 50% chance of them having a thalassemic child?
25%.
25%.
25% thalassemia major, 25% normal, and 50% that they will be carriers.
They would be carriers, all right. Okay, now let us talk about hemophilias. What exactly are hemophilias, and how do we detect them, and how do we treat them?
Okay, so here is a sort of starting with the clarification. Actually, since hemophilia is the commonest thing, so people tend to label all sort of bleeding thyroid disease as a hemophilia. Hemophilia is one of the disorders. It's a genetic disorder where female is a carrier, it's her X chromosome, and males are affected.
Right.
So, then there are other also X-linked disorders, but then there are other many disorders. Hemophilia, which is the deficiency of factor VIII, is the commonest, affects the male, females are the carriers. But you have other disorders. Some of them have autosomal dominant, some of them autosomal.
Like von Willebrand.
Yeah, autosomal recessive. So von Willebrand is another very common one, which actually affects somehow other females also affected, and they tend to have a lot of problem when the menarche sets in, and then they have. But you have problems of bleeding because of the platelets, and you can have all the factors which start off with 1 to 12 and some all cofactors. So hemophilia being the commonest, and other coagulation disorders like factor IX is another one which is used to be called Christmas disease. So that's another one which is a common one. So what happens is that these people, these children, these male boys, they first detected when they undergo circumcision. Uncontrolled bleeding. So ultimately when they have to be given plasma, and then there's a lifelong struggle where they tend to have spontaneous bleeding in the joints depending upon how much factor is deficient. We call that severe deficiency when it's less than 1%, and then you have a non-severe deficiency. Severe deficiency is where they would have a lot of problems during their teething, their trauma, minor trauma, and also spontaneously within the joints. Fortunately, the time has progressed, at least in the developed world. They have developed many, they have purified the factors from both the plasma as well as from, they have made a recombinant DNA technology, and they're able to give them factor VIII, and they can be placed routinely on them, or the home therapy. Unfortunately, we have not been able to do it, and it's unaffordable when we get it imported from there. But an average blood bank, a good blood bank, should be able to manage.
So this is also avoidable by prenatal screening and premarital screening?
Yes, it is. It is available during pregnancy before 4 months through the CVS, especially if you have a men folk, mamu, the maternal uncles, if they have a history, that means that the female might be a carrier, and then they can. And that's, yes, again, this is a preventable disease. Ideally should be prevented.
So in cases like infections like dengue, when they say the platelet count is very, very low, and then there's no other treatment other than just having juices and papaya leaves and all of that, how true is that, and how do you prevent this loss of platelets in such infections?
Okay, it's somehow the dengue is very notorious to cause low platelet count, but otherwise I tell you many other viral infections and bacterial
Really?
infections, yes, they reduce it.
Okay.
Fortunately, for a person who is not having a severe dengue, they tend to, come back, regenerate themselves. This is multifactorial. They get consumed, they are destroyed, and bone marrow is little suppressed, they would temporarily not produce it. So that's a multiperfactorial. But it's important to understand that unless there is a bleeding and you have a right person advising you who knows their job, that when to give and when not to give, it's not that only low platelet count has to be treated. This is another disclosure that I want to give to people. Somehow other people tend to say that I'll feel normal when all my labs are normal. You need to see that what this abnormal lab or outside the reference range has an implication for you. One example is like platelets. You have people who have a very low platelet count in dengue or without dengue would have a problem, and then they need to somebody need to intervene and manage that. But there are many people, just because they're below the reference range doesn't mean that they need to be treated. We need to evaluate them what we call as clinically. So yes, as if you say that papaya, it would be interesting to actually have a clinical trial on that.
You should actually, because everybody says that and suggests that all the time.
And you know what? I have a couple of experiences where the papaya leaf did make a difference. So I think it's
Let's
something
do a
of food
study
for
on
thought for our pharma brothers that
Exactly.
we need to have a clinical trial. Why not? It's a conventional Chinese medicine which discovered the treatment for AML-AM3.
So we're talking about the white blood cells. So if there are less in number, leukopenia, and then we talk about the excess in number because everything excess or less is bad. So what is leukopenia first? Let's start with that.
Okay, leukopenia is when the soldiers in your body, they have to be certain numbers
And
to
they're not
actually
enough.
effectively fight. If these soldiers get reduced, so we have a less efficiency to fight certain infections. So that is, in other words, how it manifests, how we can actually detect is that we have a low WBC's count, or what we call as leukopenia. Then you have also different type of soldiers, as you have regimentations.
Yes.
You have the granulocytes who are fighters against the bacterial infection, and then you have lymphocytes who fight other sites of infections, but they work very closely.
Yeah.
So lymphopenia, usually seen in viral infections or certain other problems, can actually lead to reduced intensity of or capacity to fight infection, and also reduced granulocyte. But sometimes they're reduced temporarily and then they come back. But then you have disorders where your bone marrow actually fails.
Yeah.
So when you have a failure, and mind you, it's also another concept that needs to be cleared. It's the liver is the primary source of production of red blood during fetal life, when the child is in the mother's womb. But later on, it's the bone marrow that is the source of blood. And especially the red marrow, and that red marrow is within the pelvis and log bones and the sternum and ribs, and it gradually is replaced by fat. So that's the source of blood. So if you have a bone marrow failure, you will have a reduction of the WBCs along with other component. And then you have certain, nature way of always producing abnormality where there's a normality. So you have disorders where you have excessive production of either the lymphocytes or granulocytes. And then depending upon what type they are, if they are normal looking, we tend to put them in myeloproliferative disorders, and then you need to have a workup for that, or you can have even leukemias when you have abnormal cells replacing all of your bone marrow.
So what is the difference between AML, ALL, and what are the symptoms that people need to look out for in case they're suspecting that they have leukemia? And then what are the possible lines of treatment? Is there survival? What is their quantity and quality of life?
Okay, quite a huge
it's a very huge question.
But yes, like anything else, you can have abnormality. Both sometimes there are genetic predisposition, which people would not know. But now, because of the whole genome sequences world over, maybe would have a place where everybody has access to that. But many people who have a genetic predisposition would get a leukemia, and sometimes environmental exposure to chemicals and radiation would make you prone to, and sometimes you just don't know. So there can be leukemia of the lymphocytes. The lymphocytes can become very abnormal and blastic, and then they can replace all of the normal marrow, and then they start infiltrating all of your normal organs, and then ultimately that was, of course, if left untreated, it's going to, the person is going to die. All of it's going to be replaced. The granulocytes and that were the other WBCs, if they are abnormally produced in huge quantities, that is what we call acute myeloid leukemias. There are different types, and that again with the same phenomena, it's the bone marrow is going to be replaced, the organ is going to be replaced, and ultimately they're going to die. Over the years, there have been tremendous improvement in treatment of these diseases, and now people are looking at cure. Okay, especially for the childhood lymphoblastic leukemia, because lymphoblastic leukemia is commonest in the childhood. So they have a very long survival. Of course, there's a very scientific way of approaching it, stratifying the leukemia on different risk groups and then managing the treatment accordingly. And then we had a development in bone marrow transplantation, a lot of them. So that's one of the salvage therapy where you don't want that own bone marrow should continue, you replace the bone marrow. We have at least 3-4 centers in our country where we have bone marrow transplantation is being done. The telltale signs for anybody having this sort of disorder would be when they would start having fatigue, fever, they have night sweats, or they will have bruises on their body, and then they would have anemia. So these are usually, and sometimes they would feel that they have a enlargement of their lymph nodes. So that sort of symptoms that will come up and that would need attention by a physician.
And what about lymphomas like Hodgkin's and non-Hodgkin's lymphoma? They say they're the better of the tumors to have, and what are their signs and symptoms? Because as a dermatologist, a lot of people come with generalized pruritus in this case, and they're being prescribed steroids and steroids and steroids, and nobody's mind ever goes to this direction.
Yes, lymphomas is again a success story with the medicine, especially the the Hodgkin's lymphoma. You can look into cure on that. And then you have non-Hodgkin lymphoma. They're just types of lymphocytes and associated cells that get malignant. They're malignant proliferation, and usually the symptoms is what we call as a B symptoms. There's a fever, night sweats, weight loss, and somebody would feel that they have a nodules coming up in their neck or in the axilla or in their groin. And if they go for checkup, then people will find out they may have enlarged spleen or liver or within lymph nodes within the abdomen. And yes, then that would need workup where you would want to take out a lymph node and look at it under a microscope and see what type it is, and then you do the treatment accordingly.
Okay. What about RH incompatibility? Because a lot of, when they have their second child, they have problems of jaundice and the child has issues. What is RH incompatibility in terms of negative rhesus factor and all of that in a mother and child?
Okay, so from the transfusion technically viewpoint, we have about more than 23 blood systems. What we check is only 2 of those systems.
Only the blood group,
the
and
ABO blood group and the RH blood group. And among the RH blood group, these blood groups are actually combination and collection of different antigens. So the commonest in RH antigen blood group is the D antigen. So majority of population have this antigen on their red cell, and we label them as RHD positive. In Pakistan, you have about 90% of people who are D positive. Those people who lack this antigen are called D negative. When does it become problem? It becomes a problem especially when the female is D antigen negative and the spouse is D antigen positive. So there's a probability, there's a chance that the child that she's expect is actually D antigen positive, and there's a normal phenomena going on that the fetal blood gets mixed in maternal blood. So when this child with having a D positive antigen mixed with the mother's blood, they would produce a resistance we call as antibody. Now these antibodies that are produced against that husband's RH antigen, which is present in the child, crosses the placenta. And when it crosses the placenta, these antibodies goes and start destroying the red cells of the child. And one of the manifestation of destruction of red cell is jaundice. So that child will be either, if it is very severe, they can have a death within the womb. That's called stillbirth. Or if there's a little milder form, then they are going to have in after birth.
And the treatment is injections during that. What
Yes,
are they injected
it's important. It's one of the antenatal checkup things, markers that you need to find out that if the female is D antigen negative, then actually we want to give her immunoglobulin so that if there is a fetal hemorrhage, it doesn't lead to immunization, because once that female gets immunized, unfortunately she remains immunized for the rest of her life. And it is usually the first pregnancy where some trigger has happened, either during pregnancy or during parturition, during labor. So once that immunization has happened, then later on all the pregnancies are going to be affected. So it's important we can do something about it and we can prevent it. And that is how we can prevent. If she is D negative, we need to give her immunoglobulins.
Okay, a lot of women complain that they have repeated like miscarriages, or their child doesn't, is not viable, the birth is not viable, and they attribute it to phospholipid syndrome. What exactly is phospholipid syndrome? Because so many of them keep having children again and again and again and losing them, and they don't know what is the reason.
You know, one interesting thing is my FCPS part 2 thesis was on antiphospholipid antibodies. So there are different types of these antiphospholipids. It's autoimmunity, where the person would develop antibodies against their certain antigens. These antigens tend to be phospholipids. They tend to, one peculiar problem with that, apart from having a low platelet count, is that they would have recurrent fetal losses and early abortions. If these antiphospholipid antibodies are because of certain other disease, like other autoimmune diseases, you must have heard about systemic lupus erythematosus, SLE. So if it is secondary, then the underlying disease has to be diagnosed and treated. But if it is idiopathic without any reason and only the manifestation is this thing, then of course then it needs obstetrical attention. And yes, fortunately we can do something about it, mainly anticoagulating these patients, because the cause of abortion is because they have a thrombosis in the placenta that leads to this thing. So that can be managed with the help of obstetrical care, and for the, as I said, for secondary you need to do that, and there's a laboratory test to actually prove that somebody is having a.
And those antibodies can also be finished or no?
Yes, sometimes with the immunosuppression, especially if it is secondary, but it's basically you treat the underlying cause. But if it is idiopathic, usually they would manifest as a thrombocytopenia, which if needs a management would need a management with maybe immunosuppression or something else. But if the recurrent fetal loss, then it has to be obstetrical management as well.
Okay, what is disseminated intravascular coagulation? It's a very scary term and people get scared of it. They say like long sitting, or does it have a role to play in that or no?
Disseminated intravascular coagulation.
It has nothing to do with DVT, right? That's completely different, or is it connected?
It is. I mean, you can, in simple words, you can have acute DIC or you can have chronic DIC as well. So in acute DIC, that's usually a very sick patient in a hospital setting in intensive care, where they tend to actually have other very difficult diseases to treat, and they would have this is sort of blood system failing. So that's one manifestation we call as a DIC. So if the underlying disease gets treated, the DIC, which is a manifestation of this, get cured. The other chronic one, as you pointed out, is interestingly, like you have a liver disorder and things, where this chronic DIC can actually make you prone for clotting and coagulation, and that's where you can have a DVT. But by the way, there's another big topic of clotting, which also falls in the domain of hematologists, and that is when they have excessive clotting of the blood. That again can have because you have a certain triggers which could be acquired disorders or conditions. For example, post-operatively you are more prone to have clotting. During pregnancy you are more prone to have clotting. Then a very long flight and stagnation of blood, you can have a clotting. But then there is a group of disorder, genetic disorder as well as acquired. Like one of them was antiphospholipid syndrome. It characteristically causes arterial thrombosis. It can cause venous thrombosis as well. And then you have other group of genetic disorders like antithrombin 3, protein C, protein S, and a list of them, where you can have clotting in different places, either arterial or venous. That can be diagnosed, and that needs to be managed with anticoagulation.
Okay. So as a hematologist, what ideal diet would you suggest? We spoke about red meat, but what ideal diet would you suggest to everybody, especially growing up and should be given to them so that they don't suffer from any anemia, any clotting, anything. So what is that ideal diet?
Even though that we are scholars and in this field, nature is always right. Nature is the best guide.
Right.
So what nature says is, I'm giving you fruits, I'm giving you vegetables, I'm giving you meat, enjoy it and do it, I'm giving you dairy products. So it's the processed food which is the problem.
Right.
And over the time, this is absolutely, everybody knows, there's a lot of hue and cry being raised that the obesity, and in our country, you'll be amazed, the figures is that 70% female obesity.
Exactly.
60% male obesity.
Right.
So what it has to do? It has to do with the lifestyle. Now the new mantra is look at the lifestyle. Lifestyle, what does it mean? What does nature say? Be
Exercise,
active. Don't
move
sit.
around.
Move
Yeah.
around. Have a healthy diet. What I am giving you, it should be fiber rich. It should be balanced. That means you have a dairy products, you have egg, you have balance of red meat, white meat, fruits, vegetable. Don't go for processed food, please. And another interesting factor which Ramzan is coming, I need to mention is that the vegetable oils that we use, it gets converted into trans fats.
Exactly.
When at what temperature? The one where you have a very repeated heating of the oil, or you have the smoke coming up, that's around 400 degrees Fahrenheit. So please repeated this thing converts into trans fat, and the trans fat is prone you to atherosclerosis and the heart attacks. So if any female, any lady, house lady is worried that my husband should remain healthy and my children and I should remain healthy, they must look into the way, it's our style of cooking.
I think
and
fresh
our
food
lifestyle.
every day, and don't keep reheating it, right?
No, please, no.
Exactly. Thank you so much, Dr. Nuzhat Mushahid, for joining us today. It was an absolute pleasure talking to you.
Me too.
One last message before you leave us, because it was, all the pearls of wisdom that you've given us are indeed so useful for every potential donor out there as well. Just one message.
Please come, serve, and make it a habit to donate. You'll feel good about it.
Thank you so much, Dr. Nuzhat. Thank you so much for watching. And as Ramzan is coming, let us pledge to ourselves that this time we will be donating blood, giving everybody the gift of life. Thank you so much for watching. Allah Hafiz.